Good morning, everyone. Good to see everybody, and welcome today. Thank you for joining us. While we're all still gathering virtually, I'm sorry to say in many ways, our conversations today, I hope, will be a little different. As the world moves towards more fully opening up, I thought it would be useful to take the opportunity to try and understand what we've learned throughout the pandemic. So we're here really today to talk about some lessons learned, and most importantly, what we can do with what we've learned. We're here to look at the impact of COVID-19 on our collective mental health, really across the societal spectrum, but particularly those with severe challenges in their lives. It's certainly quite a topic. So we'll try to cover it in 4 forums during this May is Mental Health Month period and these series of I hope, informative discussions. Today, we'll consider the view from the field, really, and from many angles. We're going to start with really the big picture, starring, if you will, Dr. Torian Easterling, the first Deputy Commissioner from the city's Department of Health and Mental Hygiene. We'll follow that today by a conversation with people with another unique view of what's occurred. Dr. Susan Bean, who's the Executive Medical Director at Health First, and Dr. Jeannie C., ICL's Chief Medical Officer. We'll conclude today's session with a conversation with Dr. Ann Sullivan, the New York State Commissioner of Mental Health. It's certainly quite a program and a star-studded panel, but it's also been quite a year and a half. I don't think you can say that too many times, to tell you the truth. So much has happened and so much has changed. I think two phrases, unprecedented and you're on mute, are probably the two most common phrases of 2020. So I think we all have much to learn as leaders in the health and behavioral health field, but most of all about learning how we can better serve people navigating our system with serious challenges in their lives. That's a journey made very, very difficult during the pandemic. And we've all asked our frontline workers to do the nearly impossible. But they did everything they could to keep our doors open and services going throughout the pandemic, even in its worst days. I'm so grateful to all staff across our industry, but certainly particularly to the ICL staff who never ever gave up on their clients, even under the most difficult of circumstances. And I know this is true for staff from other organizations and government institutions throughout the city, the state, and in fact, the country. So what have we learned, and how can we move towards those lessons forward? Particularly about needing to make real change by exploring how our own institutions perpetuate inequities in healthcare and beyond. So before we begin the first part of today's forums, we wanted to share a short video. So please share your questions after the video in the question and answer section at the bottom of your screen. So on to the video.
For more than a year, New Yorkers have seen their lifestyles turned upside down by the coronavirus. Though the pandemic is not new, some say they still can't get used to the face masks, social distancing, and restrictions.
For me, not depression, because I'm not the sort of person I think that gets depression, but definitely anxiety. There's too much uncertainty around everything, and I think a lot of people are having something called pandemic fatigue, and everyone's just, sick of it.
Mental health experts say the uncertainty and isolation is taking a toll on Americans. A new study from the Kaiser Family Foundation said that during the pandemic, 4 in 10 adults have reported symptoms of anxiety or depression. That's up from 1 in 10 adults who reported the same symptoms less than a year ago. That increased to 1 in 3 amongst COVID survivors, who are also more likely, according to experts, to be diagnosed with a brain or psychiatric disorder.
We need to make sure that we keeping that distancing, that we have that mask on, respect other people to really help with not spreading of the virus. The fact that we are here and we continue to be here and we're not going anywhere.
It affected me in more ways than one. Now I have to wear a mask. There's fear. The fear is that fear of getting virus. What's going to happen to me? With Corona thing, we can't have the groups anymore. And I miss church too. No more church for now until the Corona thing wears off.
I miss having lunch with you, Aubrey.
Yeah, me too. I miss having lunch too.
We're trying to reach out as much as possible and create a path back as we consider how to reopen services so that people can still maintain their goals of creating community networks and social networks for themselves.
So as you all have just seen, the pandemic really threatened people across the city and had pretty significant impact on their sense of their own emotional well-being. but nowhere was that felt more acutely than in communities of color and underserved neighborhoods. Sadly, probably, that wasn't a big surprise to most of us who work in this field, nor was the unfair burden on families, particularly those with children, suffering terrible losses that will affect them and their loved ones for many years to come. So I'm really pleased to start today's conversation with Dr. Torian Easterling. As I mentioned, he's the first Deputy Commissioner and the Chief Equity Officer in the New York City Department of Health and Mental Hygiene. His credentials are, I have to say, really stellar, but most impressive of all is the depth of his understanding of the challenges we all faced as the pandemic raised. I'd rather use our time in the question and answer and the presentational period. So I hope you all got a chance to see Dr. Easterling's impressive bio at the beginning of the presentation today. So if I may, Dr. Easterling, to start us off, from your vantage point, what were some of your earliest concerns as the pandemic grew and as we all started to become aware of how pervasive it was?
Well, thank you, David. Thank you for having me, and really for providing time to have a discussion during Mental Health Awareness Month. I'll say, and I think it's always important to sort of ground this in sort of a personal story, because at the beginning of this pandemic, I actually was on paternity leave. And so like so many others, I was home watching this, as a spectator and just trying to grapple with, how I was going to protect my newborn daughter, who was just born on March 1st, which is actually really the first day that we had a case in New York City. And certainly concerned my wife and I as we were just arriving home the very next day. And then also just thinking about my family and and the older adults in my family and what this all means. And so I think that's what many of us are thinking about, right? Before the professional, it becomes very, very personal. And I think that also brings a lot of the tension and anxiety, because to some degree you do feel helpless. And then also because of the role that I have, I was receiving calls from my neighbors, from residents. I live in Bedford-Stuyvesant in Brooklyn, and people were calling saying, what do I do? Should I go to the hospital? And people making really hard and challenging decisions about caring for their loved ones at home and seeing them die. And so even before I came back to work, I was thrusted into the moment just like everyone else. And I think what it brought up for me, the ongoing structural inequities that continue to exist, the unseen challenges, mental health being one of them, but really, I think that this pandemic has really shone a light on those unseen challenges that we continue to have. How we're allocating our resources, how discrimination shows up in our services, who has access to those services, and how can we really minimize all barriers. And certainly the ongoing social and economic disability that continues to ravage our communities and present even more challenges. So, I would also say that as an agency, knowing how structural racism shows up in public health emergencies, this was something that we started to think about very early on. How does our data help us better inform our operations so that we can respond and promote the health of all New Yorkers and really protect all New Yorkers? And we know that was going to be an uphill battle. And so even thinking about the limitations in our data to be able to see who is probably going to be most burdened during this pandemic. Certainly the narrative and the communication, and we know how important risk communications is, and making sure that people understand. But given the fact that there was so much that was unknown about the virus, we needed to really sort of think about our guidance and making sure that those who were on the ground in communities were better equipped. And that actually took time, and there were challenges there as well. And I would say the other part, obviously there was a lot of focus on our healthcare system, and it wouldn't even say even our primary care and our federally qualified health systems, but really on our healthcare system and really trying to make sure that our health systems were not overburdened. And so I think we certainly needed to focus more on our primary care ambulatory systems to make sure that they were well equipped. And we knew and we're hearing how community-based organizations, mutual aid societies were coming up to really, stepping up to really make sure that they were protecting neighborhoods. And so I would say those are some of the main areas that started to think about as this pandemic started to ravage our communities.
Gotcha. A couple of quick thoughts there. One, congratulations on your daughter. First things first. Yeah, Dr. Eastling, I think you touched on something there too that is unique to this particular disaster, if that's the way to characterize it, and that is it touched everybody. It touched everybody personally, and it touched everybody professionally in terms of our responsibilities to others. So I think, I think as we go through our presentations this morning, thinking about the workforce as well as those that were recipients of services is really an important dynamic here. And I know we'll be hearing from Dr. C later in the program about some of the things that we did to try and protect our employees, but I think our efforts are just what we did. So I think it's important to think about that, about the pervasiveness of the impacts of this. So I'd be interested in following up on a couple of the comments you made. As this moved along and DOHMH began to look at the data as it rolled about who was being affected, the severity of who was being affected, and things like that. What did your surveillance show you? And what were some of the lessons that you and DOHMH were learning from your data sets?
Yeah, I think I would say two things. One, the communities that were being most affected were communities that we have already been tracking and watching and monitoring for quite some time, right? And so, for folks who have continued to work with the health department in a number of different ways, how we talk about that your zip code should not determine your health. The same neighborhoods where we're seeing higher rates of premature mortality and underlying chronic conditions were also the neighborhoods where we were seeing higher cases of COVID-19, severe hospitalizations and death. But then, right, and so that's important because we're not talking about, anywhere new. But then there was also really important for us to understand how, because of the limitation of our data, and we're not disaggregating our data in a very clean way, right? And so we do not have really good ways of capturing race and ethnicity and really being able to disaggregate even within, say, the Asian American Pacific Islander community, looking at the larger African American community, or even the Hispanic community, how then you look at ethnicities across New York City. And given some of the social vulnerability in certain communities that may not be as glaring because of some of the other social factors, you're going to miss pockets of vulnerability in certain neighborhoods, and specifically in Queens, right? And we saw how Queens, parts of Elmhurst and Corona, were the epicenter. But when you look at our maps before COVID or BC, many of those neighborhoods do not light up for us in the same way as, say, North and Central Brooklyn, or in Northern Manhattan, or even in South Bronx, right? And I think that is why we really need to make sure that we are continuing to work on improving our public health surveillance system, thinking about ways that we can better report on race and ethnicity and gender, right? Not just limiting to sex assigned at birth, so that we can really make sure that we're getting to the root of these structural inequities. One of the things that we did during even our vaccine rollout, and we were doing this as well during the COVID response, really working with providers to make sure that they were reporting race and ethnicity. And one of the Dear Colleague letter that we put out is that reporting race and ethnicity helps us fight back against racism, because it helps us understand where we need to really direct our and be intentional in our our operations. And I think that's the work that we have to do, right? Dismantling these inequities head on.
So in that context, were there particular needs that emerged? You used the phrase, lit up. So what, I get the idea that there are, more COVID problems and more COVID surveillance data, but were there other needs that emerged from the data early on?
Yeah. Early on, I think we needed, more tailored messaging, and that was the work that we've been trying to do to really work with our community partners, making sure that we were bringing that message on the ground, so folks were really hearing how they can protect themselves, protect their family members. Certainly, when we did not have a vaccine, we knew what the prevention measures were. But how do we really make sure that it's translated in languages that people are speaking at home, and not just thinking about English as the first language, but what are the other languages to make sure that folks can communicate? And then I would also say that really making sure that we were building up the services that people were most familiar with and comfortable with. Just thinking about providers, federally qualified health centers who were open, who were still providing telehealth services, telemedicine services, but making sure that they were able to keep themselves and their staff safe, so that they can continue to offer the critical services, right? Because as I mentioned, we knew the high rates of underlying chronic conditions that were in the communities. And so how do we make sure that we can restore primary care services so that individuals are continuing to move forward on their chronic disease management? And I think those were really critical steps that we taken early on to make sure that we were engaging our providers and communities.
Yeah, I think the overlap, for me, one of the more dramatic pieces of information, particularly with COVID-19, was the parallels around vulnerability of things that were pre-existing conditions in so many communities of color. Obesity, we know obesity, hypertension, and some of those things are already higher than in underserved communities than they are in many others. And yet those were also the high risk factors for COVID death. So, it didn't surprise me. I really hope that one of the lessons learned out of all of this is not to ignore or accept in some ways those kinds of disproportionate effects. All COVID did, in my humble opinion, is highlight what we already knew and what so many providers were trying to address every day for decades. So, so often during some of those national press conferences, there was this sense of surprise and shock that communities of color were being disproportionately affected. And for those of us in the field, that wasn't new news or surprise. So I think we've got to continue to message those issues and in fact use this experience as a call to action and not fall back into that.
Yeah, and David, I would just also mention, in addition to sort of thinking about, the healthcare services and making sure that we're addressing, these underlying chronic conditions, which we knew were present before. I think it's also, even for providers, making it really clear during this pandemic, sort of the intersection of the social determinants of health, right? So in addition to risk factors related to health status, we also saw how clear the connection was to your occupation. So if you were a frontline essential worker, we knew that your risk factors were much higher. If you were in overcrowded housing or multi-generational homes, we knew that your risk factors were higher. And we started to see that over time. So I think it's becoming even more clear, all right, to the healthcare provider community that we really have to lean into not only sort of thinking about health status, but really making sure that we have a path forward in addressing social determinants of health.
Agreed. There's been an awful lot of discussion, and the vast majority of it very positive around telehealth and telemedicine opportunities. Do you have thoughts about the benefits at the end of the day to those same underserved communities around telehealth and its benefits or limitations?
Yeah, certainly. I think very early on, some of the work that we started to do was really to just do an assessment, right? Which providers were, had their doors open, looking at staff, what services they were offering, and if they were offering telehealth services. We knew that, there was some capacity before COVID, but certainly we did see an increase across New York City, and specifically looking at the communities that I mentioned before, those providers who were primarily serving Black and Brown communities and low-income communities, were they in a position to really continue their services? And unsurprisingly, we saw that in communities with higher inequities, social vulnerabilities, those are the same communities that did not have the capacity. And so there was sort of a lack of readiness, preparedness to really make that shift for those communities, and really needing to build more capacity for providers. And I think that is the work where government has to step in. How are we building that capacity, offering support for those providers and those community centers that are in and the communities that where we're seeing higher rates of cases and severe hospitalization. And I think the other opportunity is to really do some engagement with patients, because we know that there's more work to be done in ensuring that patients that are in these communities as well, really working in communities to make sure that people understand how this can be beneficial, particularly during a time where you are limiting in-person activity. And so one of the things that we did early on, starting around May, we started to do outreach to providers. How can we help? Right. And so if you share your patient census with us, we'll give your patients a call. And we did this with over 290 community providers. We took their providers, we took their patient census, and we called their patients, seeing if they were in a position to really hunker down and how they were doing during the pandemic. Did they have their medications? How could they reconnect back to their providers? And we supported them in making that linkage. And I think these are the ways in which government institutions can really step in to provide that service that may be missing in those gaps. And I think that's important. I think another benefit and that we started to see is the education that we can offer doing telemedicine and telehealth. And so making sure that we're thinking about, we didn't always have providers, but leveraging, our community health educators, our community health workers to share that information. And we're even certainly thinking about how we're doing that now as we are rolling out our vaccines and really making sure that individuals are getting vaccinated. And this is a way in which we can really encourage and share more information and educate the public about health provisions.
Thanks. That's impressive. That's a lot of work went into that. So thank you for that. I have a particular interest, particularly as you begin to think of the long-term impacts that have been visited on all of us on children and families. Is there anything in the data or in the work that you all did that might help sensitize all of us to the ongoing needs of kids? I mean, my own thinking on that is a lot of kids, and I just saw a study that came out earlier this week around the how many children of color didn't have access to remote learning opportunities. So for a lot of kids, lost learning associated with school, I've read that I think it's pretty close to 4,500 kids in New York State lost a loved one, lost developmental milestones, lost the benefits of after school programs. So the cumulative effect of all of these setbacks for kids have the potential really to have very long lasting effects. So I'm curious if you have any thoughts on that.
Yeah, and I think those are the points that we're most concerned about. And I think, sort of overall, I think even more glaring was the stark difference in the infrastructure for schools, particularly schools in communities of color, right? And the ability to do in-person learning and do hybrid learning in certain schools, or having access to a school health counselor. I think those were the things that we really needed to make sure were equitable across the city. In every school, how do we make sure that we're building that capacity? We also knew that not every family could sort of do the hybrid model. And so how do you also create spaces where children where their parents are working 5 days a week, 7 days a week, where are those opportunities where they can still do remote learning in a safe environment? So I think the work of the city of having our situation room to really make sure that all schools were safe as we reopened in September 2020, as we did hybrid learning while also supporting remote learning. I think that was really important because what we saw over time is that we were able to keep schools safe while kids were returning, but also making sure that we were really paying attention to, the services that were going to be really important, as you've already mentioned. We started to hear very clearly about, because of the impact of this pandemic, many children had lost their parents. And so I think that's some of the data that's starting to come out more and more, and we're certainly looking at it, looking at unmet mental health need, particularly among adolescents, and certainly we're exploring that even more. And so, I think it was really important for the city to take a step, and the mayor had just recently announced some of our mental health resource investments that are going into really making sure that we're having school mental health counselors in all of our schools, or access for kids to be able to connect telephonically to school mental health counselors, because we really wanted to make sure that service was available. And I think those are the opportunities that we're going to have to continue to look at.
So we're getting close to our time, Dr. Eastling. Anything that, I guess two things. One, from your catbird seat and all this, any recommendations for the city and the state and the provider community as we head towards whatever's next in the pandemic?
I think the opportunity for us and the question that we're grappling with, even for our agency, I think we are going to have to continue to look at how we're improving our public health surveillance system. I think that's going to be key for all providers, because we really need to know who we're serving, and so we can better serve them. And we have to be asking the right question. And it's not just race and ethnicity, but also really trying to pull in some of the other social and economic status, so that we can better inform how our operations are going to be directed. And I think standardizing that way, and I think hopefully in coordination with the state and our federal partners, we're going to get to a minimum standard in how we're reporting our data. And I think, the more that we're all on the same page, we have a shared analysis in order to advance an equity agenda, I think that's going to be really key going forward. And I think we've seen that. We heard our advocates very clearly. Why aren't we reporting on race and ethnicity, on cases and hospitalizations? And in order to do that, we have to be able to collect the information. And then I think, we're going to have to really, think about this public health system that we continue to talk about. Certainly looking at, our preparedness, what are we doing during emergency and even after in our recovery period. And that means sort of broadening our framework, thinking beyond just the biomedical model, but certainly thinking about, again, how social and economic factors are playing into it. And so, we saw a lot of great work, not only from health providers, but also from our community-based organization, and really investing the capacity of our organizations. And I know so many of these organizations are watching right now and have elevated their concerns and issues to us time and time again. And we have to think about ways. We saw how there were Medicaid waivers that were issued. There were ways in which we were thinking critically and creative around supporting our healthcare systems. How do we do that as well for our community-based organizations, so that we can really strengthen the entire system?
Great. All right. Any last word on vaccinations?
We remain optimistically cautious, both for our public health milestones, and we are optimistic where we're going as far as getting shots in arms for all New Yorkers. So, we're just going to keep getting the message out. The vaccines are safe and effective, and we're really excited about the impending news that we'll be able to vaccinate adolescents very soon.
Great. Well, thank you very much. Really insightful and helpful, and I hope instructive to everybody conversation. And that really is a perfect lead-in, I think, into our next two presenters. So Dr. Easterling, thank you much. We'll be back. I look forward to continuing our efforts on all this.
Great.
So our next presenters are Dr. Susan Bean and Dr. Jeannie C. Segue to sort of what all this looked like on the ground from that behavioral health system. So Dr. C, I know obviously firsthand the amazing ways you've led ICL's response to all this and supported the same clients that Dr. Bean was just talking about. But I guess I'd like the rest of the world to know about that too. So what was ICL's sort of immediate reaction to the stay-at-home orders, and as this started to grow?
I think that I credit our amazing staff at ICL. I know that everyone's immediate reaction was fear and confusion. And at the same time, I think the dedication of our staff, the willingness of everyone to keep coming in. And in fact, our job was to limit staff from making a lot of home visits and pulling back on that to protect our clients. I think I was just amazed by that. From the first week of March, we put into place screening procedures for every staff and client on our sites every day. And did this in partnership with, of course, all the city and state agencies. We did our own internal contact tracing, to take a step above what we could get from the medical system and make sure that if we knew that one person had any kind of COVID symptom, that we knew who they'd been in contact with and did appropriate quarantines. Because ultimately, our clients, who about half of the clients that ICL serves have schizophrenia, and many of them have developmental disabilities. We know this. This is a population and that not only has these conditions as a risk for COVID, bad COVID morbidity and mortality outcomes, but also in addition has obesity, diabetes, hypertension, all of the things that also confer poor outcomes. And so we knew this was a population at risk. So we wanted to protect those clients from unnecessary infection via unnecessary home visits, but balance that very carefully with the need, as Dr. Bean stated, for food, for medication, for clothing, for all of the basic needs that they have come to rely on our system for. And for that human touch, for the friendly voice, and for the support and understanding in a very scary time. So we did the contact tracing, we provided as much PPE as possible, always looking for different donations from very generous donors of masks, gloves, hand sanitizer, and trying to equip our system so that our staff felt safe coming to work to the extent possible. And I think really now the focus has, of course, been on vaccinating everyone that we can. And to that end, we provide town hall meetings on a very regular basis to try to reach as many staff and clients with accurate vaccine information as possible. And trying to even do small group discussions to really help promote vaccination of the whole ICL family. So those are some of the things that we've been doing. I think while there was fear, I think behavioral health, as Dr. Bean mentioned, kept the doors open. We didn't close a single program. We converted everything within a week to telehealth to the extent possible, but still made a large number of home visits because people who didn't have phone access or needed physical delivery of medications, including long-acting injectables. And we didn't stop providing that. And in addition, I think during this period when people were unable to see their primary care providers, who were very stressed with COVID management, and often the primary care offices were closed, we became, through our partnership with the Community Healthcare Network, a link to treatment services. So if somebody needed a blood pressure medication and weren't able to get in touch with their primary care provider, often our psychiatrists who had the mobile capacity or telehealth capacity would be doing that for them. We looked at rashes, we looked at all kinds of fairly serious sometimes medical conditions that came up, and were able to triage them and provide care when possible.
That's great. Yeah, for those of you that may not know, ICL has had a very deep commitment to whole health care for many years, and Jeannie's played an exceptional role, even recognized by SAMHSA, for providing health care services and improving health outcomes for people with serious mental illness. Jeannie, could you talk for a second about, because it might be helpful to some of the other agency folks, particularly as we begin to sort of flirt with reopening, how did ICL make the determinations about who needed to be seen in person, who needed to come in, and who we felt was perfectly okay being spoken to on the phone or on video?
I think it depends a lot on which ICL program we're speaking of. By and large, our clinic population, tends to be more stable and have a higher independence and lower level of need for direct social determinants supports from us. So less medication delivery, food delivery, and so forth. So most of those folks were seen with telehealth only, and came in only if they had needed an injectable medication or if they needed a risk assessment. And for many of the first visits, we tried to get folks in person, but some of them preferred to do that by telehealth, and we met people where they were at. For our assertive community treatment teams and intensive mobile teams, where the level of need and risk was higher, we would make about half in person and telehealth visits, and always following client preference to the extent possible too. Some people wanted to come in, and we would do that with appropriate personal protective equipment and screening. And some people just were kind of concerned about seeing anybody at all and wished to stay home, and we accommodated that as well. So I think at ICL, generally client preference does determine it's sort of the first priority, but we triage things by risk level and by need for concrete delivery of supplies, food, medication, and so forth.
So a question for both of you, and I'll start with you, Dr. Bean. What do you think is the greatest lesson for us all out of the pandemic, and what recommendations might you have, given that to put her on the spot before she's actually on the screen for a minute, for the state's mental health commissioner, what recommendations might each of you have for what we need to attend to going forward?
Well, two things. One is I think I'm not confident that we served our children well across the board during the pandemic. We really were not prepared for them. Most of us have heard about the difficulty in keeping up immunizations during the pandemic and preventive care and so on. And I do think and worry about gaps in serving the mental health wellness of the children and their families. Children with special needs were already struggling, at least in New York City, to get access to the services that they needed for overall health. And I don't even think we know yet what the long-term impacts are going to be with the school situation and the family disruptions and so on that occurred. So that's number one, that And at Health First, our care management group has put a whole unit just on the care of children. And behavioral health needs is a large part of that. I'm very excited to do my best to work with them, with our providers that serve children, with our behavioral health IPAs and organizations like ICL to try to think of new models of care so that we'll be prepared if we ever see something like this. God willing, we don't, but if we do that, we're prepared. I think the second, I'm going to say three. The second is that we had no, in my view, satisfactory method for people to tell us their mental health wellness needs. And we have learned from other disasters, Katrina and others, that there's an unmet, we worry about the unmet physical health and prevention needs, absolutely. But the unmet mental health need began to emerge later in the process, especially among middle-aged, young adults to middle-aged adults. And then you have the issue of the older adults who had resilience, but also stopped seeking, didn't necessarily seek. So I think we're going to have to work together to figure out how to find those that need help so that they can be some opportunity for recovery and restoration as we continue to move through and finally come to the hopefully the end of the impact of the pandemic. Was that 2 or 3? 2.5.
Yeah. All right. Thank you. Dr. C?
Yeah, since Susan got 3, I'll do 2 as well. I think these are 2 lessons I think we've learned all along, been learning, but that just became so real during this pandemic. The first, as already has been discussed, was the primacy of social determinants of health, how equity, how socioeconomic factors really disproportionately affected certain people and communities during this pandemic, and how we need to strengthen our communities with a whole healthcare approach. This is the second, but really strengthen our communities with a whole healthcare approach to right some of these wrongs. And I think for behavioral health, the amount of contact that we have with the people that we serve and with the communities that we serve, we knew that that was something that we really could leverage to achieve better health outcomes for people and for communities. And I think we know that more now, that because we have these relationships, this trust, and this frequent contact with so many of the people that we serve, when they needed something during the pandemic, when we needed to screen, vaccinate, do all kinds of things to keep them and the community safe, behavioral health had that ability. And behavioral health as a whole has to become more whole health so that we can support primary care and other specialty services, the whole healthcare system, in delivering the kind of care that people need.
Great, thank you. So Sam tells me there are a couple of questions from the audience. Sam, you want to articulate those for us?
Yeah, thanks. The first one, which I think we've discussed a little bit in the last few minutes, comes from Denise Hawkins, who kind of, I'm paraphrasing here, how does the surveillance system that Dr. Easterling talked about lead to better connections to people who are marginalized and people that we are having a hard time reaching? And, how does that get at some of the, racial disparities that we've been talking about a lot so far this morning? That's the first question.
Dr. Bean, you want to take a first run at that?
Yes, I'm going to recall what Dr. Easterling said was that the surveillance system as it stood showed real time that there was an issue in Queens that we didn't expect. I'm paraphrasing him a little bit. And I think the answer to that question is that we must go beyond the social determinants of health, which are sort of what I've been, I've been impacted, with through my life, and maybe graduate to the systemic determinants of health. And I think the surveillance data will help us much more, as Dr. Eastling was saying, and as our health equity, groups have been working on, especially the city. We have to be realistic about what the system is doing actively and what it's not doing. So I think my answer to that question is that we have to have surveillance with purpose, and the purpose literally has to be to understand what systemic issues drive inequities, period. And to then, and this is sort of my personal lesson from this pandemic, I have an urgency about addressing those systemic issues in my seat, in my company, where I am as a New Yorker. I think we all have to open our eyes to the systemic issues of our friends, family, ourselves, who are people of color, and any other ism, gender, religion, whatever it is. And we have to root out the systemic drivers that keep that inequity going, and thus in a disaster, these inequities are amplified.
Well said, well said. Dr. C, anything to add on that?
Yeah, I think I totally agree. And I think a couple of things. One thing is having data is really important. And that's one thing I've really appreciated about ICL, is that we're so careful to monitor data across our system. So thinking about like even trying to do this vaccination effort, trying to get every client and staff vaccinated across our agency, being able to know who has been vaccinated and where, being able to sort the data so that we know like where are there programs, groups of people, age groups at ICL that might be deliberating more about the vaccine than others. That's been really important for us. And I think remembering that sort of culture is not uniform. I mean, sometimes I think when I hear about sort of the Asian community, I know that there are many Asian communities, and that there's so many different microcultures here, and that some pockets of the Asian community might be more likely to be vaccinated, and then some might not. And I think really getting a better understanding through surveillance, through data, on sort of the specific, as Dr. Bean said, systemic issues that impact care is really, really important for us.
Also well said. Sam, the second question quickly.
Yeah, the other one comes from Henry Tobin, who's a member of the ICL board, and it's somewhat related. The question is, have you seen other places that are like New York City, very diverse communities, where they've maybe done things differently or had success in reaching the populations that we're really most concerned about?
Is Dr. Easterling still here?
I know. That would have been. It's a tough one because it's we're so focused on what we're doing here.
Yeah, I mean, I think the question is there someplace else we can learn from? Really, is the question there, right?
I don't know the data well enough, but Dr. Easterling might.
And there he is again. He even magically appears. Yeah.
I thought I'd just jump in. I heard my name. I'm sorry. Can you repeat the question?
The question was: are there places outside of New York City where we've seen, success in reaching populations that have been traditionally, hard to care for during this pandemic, and things that we can learn from other places?
Yeah, certainly. I think that this has been a key part of our work, sharing best practices with other jurisdictions. Certainly, sort of thinking about coordination with community partners, other stakeholders such as hospitals, healthcare systems, local community providers. Last summer, we have been working with the mayor's office in Chicago, who recently just announced a chief equity officer for Mayor Lightfoot's office, and then the Chicago Department Health had then just brought on a Chief Health Equity Officer as well, Sandy Brown, and they had launched what they called a rapid response team, and really focusing on a key area in Chicago, the west side of Chicago, how they were using data, but really granular data, and really trying to get down to census blocks and really thinking about how they can use all of their resources from messaging and then coordinating with providers to really make sure that they were connecting people or reconnecting individuals back to their providers. The data is still preliminary, but we still remain in touch with Chicago and sort of learning how their rapid response teams have been deployed and really trying to address some of the mitigation measures around transmission. And then they certainly expanded that work for their vaccine rollout. We've also been paying close attention to Vermont, where Vermont actually used race explicit language to sort of think about how they were distributing their vaccines. And so I think it was very progressive, very bold of Vermont. The governor there announced that individuals who identify as Black or another person of color was eligible to receive a vaccine. And this was really important in sort of thinking about not only underlying chronic conditions or age, or even, sort of the limitations of trying to direct resources by place. Because as we were talking about before, and Dr. Bean had mentioned, certainly when you just using these methodologies around social vulnerability index, we're going to continue to miss people. And we have to be intentional about how structural racism has impacted certain communities, and particularly Black and Brown communities. And so being intentional there. So certainly we've been really coordinating and learning a lot from Vermont. And what we've seen is that they have been able to close the gap between persons of color and the rest of the state as far as their data. And I think that has been very impactful for other jurisdictions as we're thinking about what additional strategies can we do to close the gap, but also to address hesitancy and build.
Great. Thank you, Dr. Eastman. And Dr. Bean, Dr. C, thank you very much. I think also a great discussion and lots of insights. And I venture to say a lot of the work that I've heard today already is likely as sophisticated and insightful as anything that is going on across the country. So while there's always more to learn, I've been really impressed with the efforts that have been articulated today as well. So thank you both very much, which is all really a great lead in to our last speaker, and that is the Commissioner of the New York State Office of Mental Health. And just by quick way of context, the State Office of Mental Health oversees the care and treatment of about 800,000 New Yorkers across the state with mental health challenges. So she's in quite a unique position to educate us all and to hear about some of the challenges and struggles that from a policy level that have been going across the state. And it's certainly a personal honor for me, really, to welcome you, Dr. Sullivan. I've had the great honor of working with Dr. Sullivan for many years, and I know because I've walked in at least tangentially close shoes to those, that it's an extraordinary challenging job, and nowhere more challenging than in the last year and a half. So good to hear from you. I appreciate your time with us, Dr. Sullivan. What were some of the first challenges that began to emerge early in the pandemic for you all?
Yeah, I think our main goal was to try to keep both our clients and all the staff who work with them across the state safe during the pandemic, as safe as possible, and then to make sure that access continued, access to care. And I think that was a big worry, especially when things were shut down. And I think we worked very closely with the hospital systems to make sure that there was the ability of diversion if we needed to, for individuals perhaps not to be in hospitals or to sometimes leave with big wraparound services. And that was very helpful. We did a lot of infection control. And in the community, the big thing was telehealth, I think, which was telephonic, both telephonic and virtual like this, telehealth. And getting that up and running quickly so that people could maintain their connection in the community with the people who they were working with their treating psychiatrists and therapists, et cetera. And the community, the mental health community adapted marvelously. I mean, it was so impressive. You know, in January, before the pandemic really hit, less than 2% of all visits to Medicaid were tele. By April, it was almost 90%, which was incredible. And so it was this huge switch to a different modality of working, and the field rose to this. And I think we were also helped by the governor's office and people with the emergency regulations, which ensuring the payment for these services would continue. And we did a survey of our clients, and we found about 6,000 individuals responded, which was great. And basically we asked how they felt they were being taken care of during the time. And about 85% felt they were being taken care of very well. Some of the others had some questions, but that was a good percentage. And many of them were using telehealth. Over 80% were using some kind of telephonic or telehealth, and they found it workable and okay to use. So I think that was really good news. And we did a quick measure, which we looked at prescription use. That during that period, the height of the pandemic, number of prescriptions filled in Medicaid versus last year, and they were about the same. So that made us feel a little bit as a quick, measure that people were getting services. They were able to see the people who were treating them. And it was just one quick measure that things were going as well as possible. So access and making sure that the quality of care as much as possible continued during the time. And a lot of it face-to-face stuff continued too with our AOT programs and our ACT teams, et cetera. But to make sure the care was there and that it was still safe and accessible for everyone. That was the big goal in the beginning. And we were worried about it, but it so far seems to have been doing fairly well.
Do you think there were unique effects of the pandemic on those with mental illness?
Yes, I think so. It's interesting because I think what you often see during something like a pandemic is you see a decrease in inpatient hospitalizations, for example. And I think that we've always wondered about this. This happened during Hurricane Katrina. It happened during other times. Certainly with the pandemic, there was anxiety about going out and getting those kinds of services because of the virus. But still, the impact is there, and often you see it lags a little bit, and you're beginning to see it now. So what we are beginning to see is now an increase in some crises, lots of crisis calls for the serious mentally ill, and an increase in activity in our emergency rooms, et cetera. So to some extent, there's often a bit of a lag that can happen. I think the impacts are like the impacts on everyone else. The stress is significant. People have, and for our population, often when we did the survey, we asked how many were also having problems just with food insecurity or the difficulties, with daily, the things that they need to keep them, basically healthy and safe. And there were difficulties. They're significant in our guys because we know that many of our individuals with serious mental illness are in the lower income area. So, and also in minority and underserved areas. So we know that they had the impacts of everyone else. So yes, there were impacts on individuals with serious mental illness, and we tried to work as closely as possible to prevent that from impacting into the terms of like relapse and illness, that kind of thing. But basically, I think we did a pretty good job, but yes, there were serious impacts.
Yeah, I think that's, as we think about planning and preparing sort of for what's next, I think what you just spoke to is really important, because you probably have seen too, the National Blue Cross Blue Shield issued a study that was in the Times this morning about how mental health diagnoses went down across the country by 10%. And isn't that wonderful? And I'm not so sure it's so wonderful. So.
No, I mean, it's very misleading to say that, because this is a trend that usually happens at a certain period of time post these kinds of pandemics, and then they go up. And certainly all the surveys that have been done of the general populations during the pandemic have shown an increase in anxiety, depression, and PTSD across the general population, including those with mental, across that up to 40 to 50%. So, I mean, that's interesting the way the data comes out, but there's some data that's been showing a significant increase, some that's been showing, you know, the decrease. But I think you have to be careful because often these, the impacts lag. They're not always, and the data lags with it.
Yeah, SAMHSA has a fascinating graphic that they've called about how really in a sense the stages of crisis response, and it's interesting. It really starts with the heroic period where everybody does everything they need to do. You're very focused on those things. It's high energy. There's high cohesion and those sorts of things. And then slowly over time, that goes down into what they call a period of disillusionment with people that are probably not unlike us as individuals after the funeral. You know, it's when you have a funeral, you sort of focus on those things, you do what needs doing, you get through them, and it's often the next few weeks that are the most painful. And I'm concerned, and I think from a planning perspective, we all need to be, Dr. Bean highlighted the issues of grief in so many people. And that's not just grief of loss of loved ones, which is critically important, but loss of developmental milestones, loss of friendships, loss of social activity, loss of income for so many people. So, you know, I think we're all in for a challenge in the next few years. So.
Yes, absolutely. And when you look, you know, one of the biggest determinants of individuals, sadly, you know, dying by suicide is economic. And I think that, you know, while these data so far is showing that perhaps during this peak of the pandemic, we did, you know, there was a lower rate of individuals dying by suicide. You know, when the economics begin to kick in terms of some individuals who've lost jobs, et cetera, we're very fearful that those, just as one indicator, that those rates will go up. So I think you're absolutely right that you have to look at this over the long haul, and you have to think about the impacts of the economics, even long-term grief for individuals. We know there were the United Hospital Funds showed that 4,200 youth lost parents and caregivers across the state at the height of the pandemic, and that number has gone up since the height of the pandemic. And that's a terribly high number of individuals who've lost caregivers, whether parents or the caregivers. So that we know there's going to be long-term sequelae from that, because we know there always is. So I think you're right, and I think we have to be ready for that. And that's a challenge. That's a challenge to make sure that our system of care can provide. You know, we had a 12% increase in Medicaid clinic visits in the past year. And that's good. That's good. That means that in some ways we've responded, we've been able to increase, but we also are projecting that we probably will have even a greater increase going forward. So we need to be sure that we can provide that kind of the access to care that's needed to both the general population through things like our Project Hope, which is doing a lot of crisis counseling and outreach, and then also to those individuals who have mental illness to be able to get the services that they need.
So one of the ways I think access was certainly maintained during the pandemic was telehealth, and you mentioned it certainly. What do you think is next for telehealth?
Well, I think first of all, I think it's going to be around in a much larger proportion of the services we provide than we have in the past. I think that you know, patient preference is important too, and I think for some clients, being able to do the convenience of telehealth is really helps them to be able to keep appointments, to be available, et cetera. For others, they prefer in person, or sometimes they don't have the privacy at home that they might have in an office. But I think it's going to be there. I think we're going to use it a lot. I also think we're going to use it more for groups than we have in the past. You know, we had the experience over the summer of running during the height of the pandemic, something called coping circles with groups, where we had groups of people come together to talk about their experiences and concerns about the COVID epidemic. It was quite successful. So I think telehealth can be expansive in terms of using it for individual connections, but also for group, and also for the spread of best practices. You know, I think this is going to make it much easier to do group conferences and telecommunicate, the way that we can talk about doing the kinds of supervision that we used to do, but became too expensive sometimes because of the time, can be much enhanced with using tele and various kinds of electronic collaborators. So I think there's a lot that it can offer, both in terms of treatment and learning. And I think that that's something that will grow over the years. And we're hopeful that also even telephone will ultimately be reimbursed by everybody, because I do think that, while not as sometimes as comprehensive as this, it can be very effective once you know a client, to be working with them on the telephone can be quite effective too if they can't make the broadband connections like with virtual telehealth.
Yeah, I think that's we at ICL did our own survey to see how our clients were feeling about the connections that we were making with them through the variety of telephonic and visual modalities. And to me, it was very interesting because there were a number of people, a significant number of people said that they preferred short daily contact to the traditional sort of 45-minute sit-down session. So I think some of the learning opportunities about what really works for people in what we have all, including ICL, have always touted as being patient-centric. I'm not quite as confident in that today as I might have been a few years ago, given some of the feedback we've gotten. So I think there are opportunities to be to adapt to more methods that work from the consumer perspective. And I don't mean this in any negative way, not sort of necessarily just driven by what we can fund, but what people actually feel is the most effective way to touch base with them.
And I think you're absolutely right. I think for some clients, that kind of more frequent contact, but brief, is much more valuable than we haven't been able to do it in the context of coming into an office, but we can do it now. And if you think about it for a minute, I mean, if you're talking about behavior change, I mean, the ability to do that on an ongoing basis with kind of constant, more easy reinforcement is terrific. So that's the kind of thing you should be doing. And we're looking at it for rehab and skill development, et cetera, too. I think we can do much more in terms of our pros programs and other things with skill development using teleconnections with people. I think there's a whole new world that's going to be developed there in terms of the individuals being more in control of how they are able to make the changes that they want to make in their lives on their own too, using telehealth and various phone connections and apps. I think all of that's going to grow over time.
Great. Good. That's wonderful. So I think all of our presenters today, including yourself, Dr. Sullivan, have sort of mentioned the anticipated increased need for services going forward. And as we are all beginning to struggle with what comes next, struggle in a good way in some ways, but what kinds of policy changes in service adaptations do you anticipate coming in the next few years?
Well, first of all, I do think there's going to be what we just talked about telehealth. The second is I think we also learned that our system of crisis services needs to be really enhanced and developed in a more robust way. There were lots of calls to our crisis lines, to various helplines, et cetera, sometimes from people, including our social emotional helpline with Project Hope. And we're learning a lot. We're learning a lot about what people need in terms of both those who have a serious crisis, mental health crisis, but also the average person who goes through their own crisis where they may want to just talk to someone for 1 or 2 times. And how do they get access to that? How can they have that? We have to really begin to rethink that piece of the access. So I think what we're learning is that we need to have a kind of response system that is very easy for the public to access. And I think that will be helpful when the 988 number comes in. And as we're getting some funding from the federal government, we're going to be using some of those dollars to develop a crisis system that will deal with the high-end crises as well as the lower-end crises, the ones where individuals maybe need to talk to somebody immediately and can't just necessarily wait for a couple of day appointment, that they could walk in, get the help they needed, and if they need more, then move on to the other part of the system. And I think that's something that we really have to develop in a much more robust way than we have in the state. We have pockets of it, but we don't have it statewide. So that's going to be, I think, a major initiative over the next year or two to develop that kind of system.
Great. So all of our previous presenters have also mentioned their concern about the long-term impact of all of this on children. And you mentioned earlier sort of the probably now closer to 4,500 kids that have lost loved ones. They've lost school and friends and developmental milestones and after school programs and the like, particularly in communities of color that had much fewer opportunities for those digital connections as we're starting to learn. Any thoughts about the needs of children and families?
Well, I think they're big, and I think they're going to be become very prominent as the schools reopen in a big way, and as kids go back to school. Some are already going back to school in the fall. So, we've been working very closely with the school systems too across the state, and some of them have been in terms of the helping them develop the kinds of programming that they will need to work with kids and families and the parents when the kids come back to school and help them adjust to what can be, think if schools are open, everything will be great, but it's like I said, there's these delayed reactions and kids coming back into school. There was $10 million in the budget to work with schools in high need areas to connect the schools with mental health resources and also to help the schools develop the kind of programming that they need. And there's 230 school districts, which were chosen largely because of need. So that's a new way to approach things, not just sending out everybody in the schools and then whoever responds, but looking at particular communities that we decided. We worked on this with SED, this education department, and those dollars will help to develop those connections between mental health services and schools. We've also greatly increased the number of school-based clinics, and we want to continue to do that. Mental health clinics have been very successful in schools. A couple of years ago, we had like 200. Now we have almost 1,000 in the school systems. So we're working with the school systems to do that, to connect the services, and then doing a lot of outreach in terms of trauma-informed care from our trauma-informed network to go to work with the schools. So the schools need assistance. Some of them are further ahead than others, but we're there working with them to be ready when the kids come back. And then also to have those critical connections with the services in the community, because too often the schools haven't been as connected to what's mental health in the community. They don't even know sometimes what's really there. So we're in the process of setting that up. And then we will also have the crisis network that hopefully can work more closely with the schools in terms of kids who get into acute crises, rather than using emergency rooms and that kind of thing, which isn't the best.
Right. Where they get an assessment and then get sent back to school.
Right, exactly. So with those connections, those long-term connections that are so important, and also doing some work with, I think we have to reach out more and more to parents and families to understand the impact that this can have on the youth and to keep, know the warning signs and to feel comfortable asking for help, which I think is a big issue. People are still sometimes reluctant to ask for help, even if they do see some of the signs that their child may be having problems. And we need to keep that door open, make sure everybody asks if they need help.
That's very helpful. And just a reminder to everybody, our session next Friday in our May is Mental Health Month series is on the needs of children and families. And we're very happy to have Dr. Linda Henderson Smith from the National Council for Behavioral Health talking with us around what's happening across the country to support kids and families. So Dr. Sullivan, last perhaps opportunity, anything about vaccinations?
Well, we're working real hard on vaccinations. OMH, we just felt that we had to be a part of helping our provider community get vaccinated, and also our patients get vaccinated. So we've given out now, I think, over 80,000 vaccinations across the state. And our primary goal is for individuals who can't easily make it to vaccination centers. So we've done a lot of mobile outreach. And we're still here and available to do it. So I'm doing a little bit of an advertisement here. But if anyone has a place where they feel that it would be important for us to come as a mobile team, and we'll come for a few people, we'll come for a lot of people, and get vaccinations because their clients are having trouble getting to vaccination sites, even though things have opened up, we'll be glad to be there. You just have to call our field offices and they'll connect with you and get you exactly what you need. So we've been really pushing there's still a tremendous amount of vaccine hesitancy out there. And I think we really all have to work on this. One of the things we found in the state system, working with our clients, that you really have to keep asking, keep explaining, keep educating. We got our numbers up for inpatients from what was started out as like 40, 50% up to almost 75% by continuing to kind of talk with the clients about it, having peers talk with them about it, say why it's safe, why it's important. And we know that our population is at such high risk for the comorbid conditions they have if they should get sick. So please you have to keep talking about it. You have to keep working at it. We're trying to make it as easy as possible. If anyone needs any assistance in getting vaccinated, we're there to work with you, to help set up mobile spot-on clinics or whatever, anywhere where we've gone to residential programs across the state. We've gone to, especially upstate, to some of the smaller shelters because they don't have the resources that sometimes the city has in terms of the vaccine. So please come. And I think that we're getting there. We're getting there, but we're still less than the general population accepting the vaccine. And that's a problem. That's a problem.
Agreed. So we all have work to do still. No question about that. Well, Commissioner, thank you so very much. I really appreciate all that you're doing. This is I know that that's a challenge and a half job in the best of circumstances, and we've all had a unique set of circumstances over the last year. So thanks for all that you've been doing.
And I really want to thank ICL. You've been terrific throughout all this, and all the providers out there have been. It's a very. I just feel so proud. I mean, mental health community has just risen to the occasion here in terms of taking care of our patients, taking care of their families, taking care of the staff. So, I mean, everyone's done a terrific job, and it's just been a tremendous experience to work with everyone. So thank you all for what you've done. It's been terrific.
Wonderful. Thank you. And thanks for that, too. So this has really been, I think, a terrific session as we begin to begin the end of this particular session. I'm really honored to have all of the guests that we've had with us today. Certainly well-informed and thought-provoking discussions. And let's all continue these discussions and learn more from each other next Friday and in the subsequent two after that. We'll be focusing, as I mentioned, on children and families at our next session. And then in the following that, issues around the homeless community, congregate care, and supported housing. And how we can all think about the impact of the pandemic on those populations and some best practices to do our best by those folks. If you want any more information on any of these upcoming issues, please visit iclinc.org/policy sessions to learn more about the topics that will be discussed and the timing and the like. Certainly, I have been, as the commissioner was kind enough to say, extremely proud of the work that our industry has done throughout all of this. It has been, and perhaps it's an overused word, but I think heroic, and I mean that in its most literal sense. We're a community that works together to help people lead the healthiest lives and most fulfilling lives they can. And I think we've risen to the occasion extraordinarily well. So I hope as we rebuild and reopen, as we close to the way things were before the pandemic, and we learn and adapt in better ways to take good care of people, that we use our own learnings. And I hope these sessions that we're doing over the rest of the month will be instructive and help all of us do exactly that work. So take care all. I appreciate your being with us this afternoon, and we'll see you next week. Thank you very much. Take care all.